COPD, chapter 2. What do we do for these clients who have all of these problems from the emphysema and the alveolar sacs deteriorating and getting hypertrophy and not being able to do gas exchange? And then we have these bronchioles that are all sorts of inflamed and creating extra mucus, and then that the stuff isn't getting through. What do we do? What do we do? What do we do? Here's what we do. Let me share my screen. So one of the first things that we're going to do is we are going to in the course of our working with the patient, we're going to be developing some possible treatments, and we're going to be working with these particular, the pharmacological and the oxygen therapy, we need orders for. So those are going to be primary care provider orders. We can work with anybody on smoking cessation as a registered nurse. It's part of our scope of practice. So possible treatments for COPD include smoking cessation, oxygen therapy, and pharm interventions. Smoking is the most prevalent cause of COPD in the US, which is why I have it listed. And so every COPD patient should be counseled to quit smoking in order to slow or even halt the progression of those two disease processes. Oxygen therapy should be used judiciously. What can happen is if we get them too much oxygen in their arterial blood, so 65 milligrams of mercury arterially, it actually causes them to slow their breathing. And then because there's and hypoventilation, and then that will actually increase their serum carbon dioxide levels. And so we're not moving anywhere towards where our goals are. So when it comes to pharm, we're commonly pairing some different things or combining some different things together. We are going to be using long-acting and short-acting bronchodilators, along with anticholinergics to manage the disease day-to-day. So we have our day-to-day management here, and then, our day-to-day management here. And then we will also, because respiratory infections are especially difficult for this particular population to combat, they may be getting some antibiotics or antifungals, antivirals. But what's more important for these particular people, rather than treating their infections with the antibiotics, antifungals, antivirals, whatever is appropriate depending upon what they have going on, is to actually just get vaccinated for everything that they possibly can. The flu shot should be coming every year for these people. The pneumovax or the pneumonia shot should be coming every 10 years. It's not uncommon for antibiotics prophylactically, but due to the rise of methicillin-resistant Staph aureus and other resistant bacteria, prophylactic antibiotics are not as prescribed as much as they used to be, but they still are prescribed by some providers. So moving on to the next slide. What nursing interventions can we provide, and what for these possible nursing diagnoses? Because these people aren't breathing, they have activity intolerance. Because they have increased CO2, they have anxiety. They're at increased risk for infection, or they have an infection. Imbalanced nutrition, we talked about that just a little bit ago. In chapter 1, they have an ineffective breathing pattern, they have impaired gas exchange, and they have ineffective airway clearance. These are all associated nursing diagnoses with COPD, and we can see, and when we were talking about the pathophysiology in chapter 1 of this video, we can see all of those nursing diagnoses coming into play. So there are many, many different nursing interventions that we can use to help with these nursing diagnoses. And a lot of these interventions will end up impacting more than one diagnosis. There's not direct, like only this intervention will work for this diagnosis. A lot of like this intervention will work for 1, 2, 3, 4, 2, 3, 4, 5, however many different nursing diagnoses that we have. So ineffective breathing pattern, we can teach them breathing techniques. That pursed lipped breathing We can also help them maintain their airway, by independently expectorating, by hocking up loogies, getting that mucus out of the way. We can also, maintaining the airway as far as mucus is going. If you haven't watched tracheostomy, we give humidified air to people to be able to keep their secretions thin. They can keep their hydration status up. They'll be able to move that mucus. So we're also encouraging these people to increase their fluid intake to be able to keep those secretions thin so they can maintain their airway. Monitoring for changes. Sometimes we do oxygen therapy. We help them with their drugs. We do cough enhancement techniques, dyspnea management. How do you cook Thanksgiving dinner for 15 people that are coming over? Perhaps you have potluck, so that you don't get out of breath and overwhelmed and you can't do it. There's pulmonary rehab, there's suctioning, there's positioning. A lot of people who have COPD will be tripoded, where they'll lean their elbows on the table and they'll scoot their butts back, and that exposes the biggest surface area of their lungs to the tippy top so that they can do gas exchange that way. We'll help out with anxiety through chest physiotherapy, establishing plans for flare-ups. We're going to be working with them on energy conservation. We'll work with them on small frequent meals. Sometimes an ensure shake is this population's best friend. And then for infection, we'll work for prevention with vaccinations, as well as other prevention techniques. So unfortunately, smoking is still prevalent in American society. With the advent of vaping, inhaling irritants is not likely to be eradicated anytime soon. So COPD isn't going anywhere either. So key points. Remember, COPD is a combination of chronic bronchitis and emphysema. The two disease processes make it difficult for oxygen and carbon dioxide to be exchanged from the alveoli and from decreased airflow, and then increased inflammation processes. The increased inflammatory responses destroys the walls of those alveoli, and then it also decreases the openings of the bronchioles, and it increases mucus production in the bronchial tubing. So that's going to be creating a situation where we have decreased serum O2 and increased serum CO2. The body compensates by increasing the respiratory rate, coughing, and increasing RBC availability, and then it causes accessory muscles to be used for breathing. Interventions can include maintaining airway, medications, getting rid of that mucus, quitting smoking, oxygen therapy, pulmonary rehab, lifestyle changes, and then education regarding the disease process. So as always, here are my references at the end of this particular slideshow. I'm going to stop sharing my screen. And as always, if you have any questions about this, bring them to class, email me them, get them to me somehow, get them to Natalie somehow, and we will get them answered for you. This information can also be found in Lewis. So please use your references, use us instructors, and have a great day.